gonna start into tumor progression. We're not as behind as we thought as I thought we were. I realized we also have next week. I was like, we have to finish on Friday. Yeah. Pretty chill. Okay, progression. So we've talked a lot about initiation, promotion. Now we're in progression. This is how we go from a benign tumor to a malignant tumor. So everything we're talking about from this point on is going to be the features of malignancy, growth, and spread. Okay, so I always get this question during this module. Are benign tumors precancerous? If we think of cancer as a malignancy, right, in the human sense of the word. No, not all benign tumors turn into malignant tumors. Some do. Depends on what type of tumor you're talking about. It depends on what organism you're talking about, what species am I in, what's the location, what environment are these in? Are we in an environment that is causing us to develop neoplasia? Do we have high exposure to carcinogens? Do we have a lot of exposure to promoters, chronic inflammation? Then we have a higher chance of progressing, right, if we're under those stimuli. So a couple examples. Leiomyomas in the uterus, so those fibroids we talked about, very, very, very rarely progress to malignant tumors. They are almost always benign and they almost always stay benign. However, there are tumors that almost often do go from benign to malignant. One of those is colonic neoplasia. So adenomas in humans often undergo malignant transformation. Carcinomas, this is why we all get ourselves screened after a certain age, looking for benign tumors so we can take them out before they can become malignant. That makes sense? So the answer is it depends on this one. Neovascularization. So this is the process of creating new blood vessels to feed the tumor. Tumor outgrowing its blood supply is a selection pressure. Hypoxia is a selection pressure on tumor cells to develop additional mutations that help them survive in the hypoxic environment. One of those things is induction of angioblasts and neovascularization. So again, malignant tumors, this is often a feature of malignancy. They're becoming necrotic because they're growing very fast and they're outgrowing their blood supply. Yeah.
Do malignant cancers have a specific kind of process that they like coagulative or liquefactive?
What do you think it's going to be? Because you know the causes now of what causes coagulative and liquefactive.
Probably more coagulative.
Is there anything? Be brave. Do we agree with our colleague? Agree? Disagree? Disagree. Somebody disagree. Yeah, what? What's the problem? The cells? Yeah, how fast are the cells dying in the middle of a tumor? Coagulation occurs when I cut off the blood supply immediately and they die so fast they don't know they're dead. That doesn't sound like tumor stuff. So I disagree. I think it's going to be liquefactive the majority of the time. And in my experience, that's liquefactive.
But I'm assuming that's not like a sex. It's not like every tumor you.
I would say it is theoretically possible that the middle of a tumor could have coagulative necrosis, but it's highly unlikely. You would need like a tumor embolus to occlude a big vessel and cut off all blood supply to the tumor all at once, which isn't going to happen because it's doing this.
Yeah.
Right. So I would argue that this is another one of the reasons that you're not going to see coagulative, because it's making sure it has enough blood for itself. It's taking care of its own. It's a really great question though. What kind of necrosis? So that has to do with inflammation. Necrosis is pro-inflammatory, but inflammatory disease, if we look in this tumor in these necrotic areas, inflammation is not going to be the primary thing we're seeing. We're seeing dead tumor cells, right? And the inflammation that's there is just coming out. So it's not really going to be caseous. That's very much an inflammatory. Okay, so again, this is a selection pressure. It's going to favor growth of tumor cells that can produce pro-angiogenic factors. such as VEGF, fibroblast growth factors, lots of other things. So this is where we're starting to talk about that tumor microenvironment. And this is one of the more important tumor microenvironment interactions is the tumor is able to induce the normal angioblast to come in and feed it. That's crazy. Cancer is so creepy. Me. Importantly, angiogenesis. Remember, we talked about granulation tissue, how leaky it is, how poorly competent those new vessels are because they're babies. It's fine. They're very leaky. They're like new capillaries. This is a good thing for the tumor because this favors metastasis. We have lots of gaps between our endothelial cells where things can just crawl in and leave. So this is bad for everybody. We're feeding a tumor, we're letting it grow, and we're also creating vessels that make it more easy for it to metastasize. They're also tumor vessels are weird. They look funny, they're disorganized, they're tortuous, meaning like they wind around a lot. Because of this, they're really predisposed to thrombosis. The body does try to block this process. Arguably, it does a poor job in a lot of cases. Okay, so real quick, almost done. Here's a normal capillary bed. So we go from arterial to venous and back and forth. And capillary bed is mostly limited permeability. It's pretty well organized. It's very stable. This is a tumor capillary bed. It's a mess. It is not well organized because it's not being driven by the body. It's being driven by the tumor, and a tumor should not really be put in charge of things. Tumor makes a bad boss. Makes for a toxic work environment. So here is a case I had of a chemodectoma in a dog, and you see all the blood vessels on the top of it. You see how tortuous and twisty and weird and big and crazy they look? That is tumor neovascularization. So someone asked about this being neovascularization. I don't know, it's probably in there. I don't really see it. This is what I'm talking about. Big, weird vessels often crawling over the surface. It kind of looks like a brain, right? Like a weird brain with meninges on it. Anybody know what this is? Where does this come from based on the name? Is it benign or malignant? It's named like it's benign, but this is a malignancy. Sorry. No, I hate it. Hemodecant. Something chemical. Where are we? What's this? That's trachea. So we're in the chest somewhere. Chemical something. Sorry, it's a really hard one. This is a heart-based mass. Also called there's also carotid body tumors. These are like your CO2 sensing cells in your vascular system. So they're neuroendocrine, which is sort of epithelial. It's kind of its own category. There are secret categories I didn't tell you about, so I don't want to confuse you. It's neuroendocrine. Now I'm going to go on to how neoplasia is. So all tumors can grow by local expansion. That's that expansile progressive. Both benign and malignant tumors can do that. If we're benign, that's the extent of spread by definition, okay? Local invasion into surrounding tissues. If you're poorly demarcated, if you're sending little creepy crawling fingers into the tissue, you are malignant. That is an indicator of malignancy. Metastasis is an indicator of malignancy. So leaving where you developed, going through the blood or lymph or a body cavity and implanting somewhere else. These things define malignancy. Number one is metastasis. Number two is local. There are different forms of metastasis depending on who you are, how you're traveling. Sometimes tumors like to go through the blood. Some prefer to go through the lymph. Some of it is governed by tumor type. Some of it is governed by tissue microenvironment. Some of it is just bad luck. If we're talking lymphatic spread, think about the anatomy of the lymphatic system. It's going to drain into the lymph, and then it's going to go to the lymph node, and that's going to be the first place it plants. Whereas if you're coming through the bloodstream, if you're hematogenous metastasis, you're gonna settle out in the blood filtering organs, so lung, liver, spleen, kidney. The big guys. Trans-coelomic implantation, a coelom is a body cavity, so like things that don't have a diaphragm have a coelom. So trans-coelomic means it's spreading within the cavity, like in lab the other day, we had a carcinomatosis. That would be this, so carcinomatosis is spread inside the body cavity, basically seeding of the serosa. And then briefly, we're gonna talk about direct contact. These are the coolest tumors, but they are not very common. Any questions so far on metastasis? It's a pretty big topic. Okay. Epithelial to mesenchymal transition. We are talking about specifically malignant epithelial cancers. So this is a feature of carcinomas. We are de-differentiating. We're epithelial cells that are de-differentiating and becoming less like epithelial cells and more like mesenchymal cells. So we're going to lose these well-behaved epithelial features, things like adhesion to another cell, things like polarity. Remember, I should be growing on a basement membrane. I should have a bottom and a top, and they should be different. I should have contact inhibition. So remember when we were talking about healing, contact inhibition in epithelium means I'm growing to repair a defect, but when I bump into other epithelium, that's a signal that I should stop growing because we've covered the surface. My job here is done. Don't want to keep growing and cause cancer. So when cells lose contact inhibition, they contact each other and they keep off each other. That is a feature of neoplasia. Attachment to a basement membrane. So an epithelial cell has to be attached to a basement membrane in order to survive and function. These guys lose that feature. So they can detach, float away, enter the bloodstream, be totally fine. No rules for these cells. At the same time, they're losing what we think of as well-behaved benign epithelial features. They're gaining these concerning mesenchymal features. So if you think of the prototypical mesenchymal cell as a fibroblast, this is a cell that is modal. It can crawl through tissue to get to where it needs to be. It can individualize, so it doesn't need other fibroblasts in a group. It has no problem just going off on its own. Oops. And then matrix remodeling capacity. That means these cells can actually secrete substances or recruit substances that cause the matrix around them to be digested and degraded, which allows them to move more easily through connective tissue, right? So if you're able to break down collagen, if you're able to break down basement membranes and blood vessels, that's going to favor invasion and metastasis. So when you see epithelial to mesenchymal transition, this indicates an increasing malignancy in behavior because these are factors that favor invasion and metastasis. This is not metaplasia. Why is this not metaplasia? It's already neoplastic. Okay, so metaplasia would be reversible, right? You think this is reversible? Nope, this is due to lots of genetic alterations.
Isn't it because they're not the same?
Ooh, it's actually not changing lineage. It's acting more mesenchymal, but it is still epithelial. These are still epithelial cells. They're just becoming less differentiated and they're acting like mesenchymal cells. So it's not metaplasia because there isn't really a change in cell type. There's just a change in phenotype. That makes sense? So when an epithelial cell gains a mesenchymal phenotype, all of these capabilities and loss of these capabilities increasing malignancy, but it's still a malignant epithelial cell. This is still a carcinoma. We can't turn from a carcinoma into a sarcoma. Fortunately, there is such a thing as a carcinosarcoma, but don't worry about it. I don't worry about it. Worry about it a little bit. Sometimes at night, carcinosarcomas keep me awake. Is it carcinoma? Is it a sarcoma? Okay, so metastasis is the #1 most reliable feature of malignancy. If it has metastasized, it is malignant. So that's the definition, right? The second most reliable indicator is local invasion. Is it crawling into other tissues? Let me explain this photo for you. We are looking at, this came out of the abdomen of a dog. The head is up here, tail is down here. This is the ventral surface of the liver, so the abdominal surface, diaphragm would be up here. This is the caudal vena cava, and we've actually cut it open. This little flap here is showing inside of the vena cava. So this nodule is inside of the vena cava. Here's the main mass. This is a pheochromocytoma. Does anybody know who the cell type of that? Cell type of origin? Who? Chromaffin cells. Where? Adrenal medulla. Yeah. So this one, it doesn't obey the nomenclature. It says OMA, but this is a malignancy. It happens. Sorry. These very commonly locally invade the caudal vena cava. Do you think this has the high potential for metastasis? Follow me. Yeah, we've eaten into a blood vessel, right? And we are now growing into the vessel. What might be some other complications of this for the animal?
Obstruction.
Well, one at a time. I heard destruction of something. Overproduction of hormones. Yeah, this might be biologically active. It would be a paraneoplastic effect. Yeah.
Poor venous return.
Poor venous return. Take that further.
Cardiac output.
Well, yeah. How about no venous return? Could this be completely obstructive at some point? What if little chunks break off? Then it's thromboembolism. Beautiful. This could cause a lot of bad things. Okay, so cut this image in half. Benign over here, malignant over here, right? Benign, we're well demarcated, encapsulated. We're growing by expansile compressive growth. Over here, we've blasted through the capsule. We're invading in normal tissue. So hallmark of malignancy. Metastasis. This is a complex process. We are still trying to understand what all governs this. It's a major area of research. But there's a sequence of events. So if you think about each of these being an additional mutation, right? The cell gets to be able to do this. So first I have to be able to leave the primary tumor mass and go off on my own, right? If I'm a mesenchymal cell, that might be easier for me than if I'm an epithelial cell, right? I have to be able to not just come off the bulk of the tumor, I have to be able to go somewhere. So I have to be able to get through the matrix of the body. I have to be able to do some breakdown of connective tissue, degrading collagen, elastic lamina, stuff like that. So I have to gain the ability to degrade matrix proteins, right? These are specific enzymes. I then have to intravasate, vasate meaning related to the blood, intra meaning I have to go into the blood, right? So that's another invasion step. I have to be able to basically break down this barrier and get from the interstitial space into the bloodstream. I then have to extravasate. I have to travel somewhere and get out of the lumen. So I then have to figure out how do I attach like a leukocyte migrating, right? I have to somehow get out of that blood flow and stick to the wall and migrate out. Each of these is an additional gain of function, right? These aren't things that normal non-white blood cells should be able to do, right? And then once I leave the vessel, I have to be able to grow at the site of metastasis. So I have to be able to colonize. I have to be able to divide. I have to be able to evade the host immune system at this site, right, in order to be a successful metastatic. The ability to metastasize is not equivalent between tumors. So some tumors are extremely metastatic. They met early in the course of disease. Things that I tend to think of as really quick early metastasizers are things like Actisaca, anal sac adenocarcinoma. Mets to the lymph nodes super fast, usually before you catch it, it's in the lymph nodes. Hemangiosarcoma metastasizes really early. Osteosarcoma metastasizes really early. Some tumors that are malignant almost never metastasize. So most soft tissue sarcomas, they grow by local invasion, they are malignant, but they rarely metastasize, and when they do so, it's very, very late in the course of the disease. Like someone noticed this years ago and decided to let it get the size of the basketball, then it metastasized, right? So very different ability to metastasize between tumor types. For who goes where, in general, the most common place to see metastases are organs with high blood flow. These are gonna be your filtration organs, so liver and lung, spleen and kidney. Those are the big guys. Draining lymph nodes also, if we're going by lymphatic route, so lymph nodes more common for lymphatic. Hematogenous spread is gonna be primarily liver, lung, spleen, kidney. But can go anywhere, right? If we're coming through the blood, it can go anywhere there is blood supply, right? So it can metastasize to the skin, go to the brain, go anywhere it wants to. Some tumors have a preference. Some tumors really like certain microenvironments. They're able to be successful in certain areas. Again, factors that govern metastasis, like who goes where, are poorly understood. We think it has a lot to do with microenvironment. So for whatever reason, urogenital neoplasms, things like transitional cell carcinoma, static carcinoma, they really like to go to the bones, which is kind of weird. Not a lot of tumors go to the bones. But for whatever reason, the microenvironment in the bone is favorable to a lot of urogenital neoplasms. In cats, pulmonary carcinomas often met to the digits. It's called feline lung digit syndrome. So if you see a really disgusting lytic tumor on the toe of a cat, please x-ray, get a catogram right now. Just in case. Not every tumor on the digit of the cat is going to be a metastatic pulmonary carcinoma, but pulmonary carcinoma likes to do this in cats. So if you see this, especially if you biopsy this and it comes back as some weird carcinoma that doesn't make sense for a foot, like an adenocarcinoma, right? You have an adenocarcinoma on a toe. What's adeno in the toe? Right, you can have sebaceous glands, you can have apocrine glands. If it's not one of those two, this did not come from me. Make sense? Carcinomatosis is really common in animals with either ovarian or pancreatic carcinomas. I had a pancreatic one for you in lab for the cat. Here's an ovarian in a chicken. So that's that trans-coelomic spread. All these little nodules in the coelom are carcinoma. Yeah, I know what I'm saying. We've covered this a lot, so pattern of metastatic lesions is going to be the same as any embolic pattern of things, whether it's bacteria, tumor cells, blood clots. The pattern is going to be an embolic shower, so like you shotgun blasted an organ or tissue. If we think about the pathogenesis of metastases, these events are usually, the cells are coming through the blood at the same time and seeding an organ, so they're going to be growing at about the same rate. Technically, each metastasis is going to be a new subclone and grow a little bit differently, right? Because that's a new population. But in general, they're going to be roughly the same size because they're all kind of growing together. They landed there together, they're growing together. There is some divergence. You see, like in here, we have one big one, and some that are not quite so big. Same here. Some of these are big, some of these are pretty small. What I notice here is that all these big ones are about the same size, and then all these small ones are about the same size. So I wonder if we got one shower, then things grew, and then we got a second shower. We have another population that's growing together. Maybe, no. Anybody having any problem seeing these lesions or the embolic pattern, or want to talk about any of the images at all? What's
Can
up?
we talk about tumor microenvironment with respect to the size of these things? Like, can we have different tumor microenvironments in the same organ type?
So if I have a really big solid tumor, the middle of that tumor is going to be hypoxic, acidic, and not very compatible with life. But the edges of the tumor are going to be more like the normal organ microenvironment. So even within one tumor, you can have different microenvironments. Yeah.
Can you explain what the organ is, what's going on in the top left thing?
The top left what organ or tissue are we looking at?
Oh.
It's a bone, so this is a long bone cut in half, and we're looking at the marrow. For this, I would say the marrow cavity of this long bone. I would say maybe 60 to 70% of it is effaced by multifocal to coalescing or white poorly demarcated foci. What do you see that? Bone mets. Could be a TCC. We good with the rest of these? Okay. Good with this? Supercalifragilisticexpialidocious. So every nodule here. They look like lymph nodes. This is bird. Birds don't have lymph nodes. Hi.
Just because I get hung up on this, it's not diffuse because it's not through all of the tissues, it's like discrete little nodules.
This?
Yeah.
Oh, yeah, I would call this multifocal to coalescing peritoneal carcinomatosis or coelomic carcinomatosis. Good question. All right, now to the cool but uncommon tumors. There are a small handful of transmissible tumors. Transmissible meaning they spread like an infectious agent, but importantly, these are not caused by an infectious agent, right? These aren't like the retroviral or the herpes viral tumors where an infection is inducing a tumor. These cells themselves, the tumor cells themselves, are infectious. They can transmit from one individual to another individual with no involvement of an infectious agent. These are also called contagious cancers. Essentially, what you need is you need a kind of inbred population so that everyone in the population can serve as a host to this tumor cell. So a lot of dogs are kind of inbred from what we've done to them. We see transmissible venereal tumors. Anybody ever seen one of these in real life? They do exist. I've seen like one. I like never expect them in this. You've seen two of them? No fair. Share, biopsy them. They are not super common in this country. They're more common in the South. Where were you when you saw it?
Guatemala.
Guatemala, not in this country. Doesn't count. Just kidding. It counts.
What's wrong?
So yeah, this is a uncommon in this country tumor of dogs. It's a macrophage origin. And it spreads by social contact or through breeding. So tumors will be urogenital or on the face from sniffing. They can be in the mouth. They grow pretty rapidly, but they spontaneously progress, which is pretty cool. This one is a little bit more concerning from a ecological standpoint. Has anybody heard of this yet? Deverell facial tumor disease. This is a Tasmanian devil. So this is another transmittable cancer that is a Schwann cell origin. It's a support cell of the peripheral nervous system. And this one's transmitted by biting and fighting. So lesions are mostly going to be on the front half of the body, especially on the face, neck. Tasmanian devil populations are extremely inbred. So this is a very genetically homogeneous population, which is aiding the spread of this tumor, right? Because it's like the population is like one big Tasmanian devil, and the tumor can just spread between them because they're very similar genetically. This is a new one. I guess 2016 is not really new anymore. It's almost 10 years. We've also discovered clonal transmissible cancers in clams. Transmissible between clams, not between clams and the people who eat them. Who's studying that? These guys.
Michael.
My bro, Michael Metzger. Actually, it's this guy, Stephen Peacock. The last author is the PI. This guy did the grunt work. This guy paid for it. These people helped. Questions about progression, spread, metastasis.
So we were talking about yesterday in immunology, we were talking about cancer, we were talking about transmissible cancers, he brought up virulent disease, and Professor Day said that was due to a viral infection, not I thought he was trying to say they can spread it from one to the other, but the cancer is caused by a virus.
Not that one.
So is the origin of the cancer, someone at some point had cells infected by viral disease and it became neoplastic and then they spread it and that's just been spreading.
No, this is thought to be non-infectious in origin. Unless there's been some very new research that I am not aware of. I'll look into it. Anybody find the paper that tells you that TBT is infectious origin and not an infectious cancer? So, teach me. But as far as I know, no virus included. Other questions? What is the primary indicator of malignancy? What's number 2? That's it?